those paying attention to that. All these companies, a lot of regular large companies, I'm sure. From your FDA.
That's where they came from. The agency's pretty large, right? 10,000 people, of which unit people are with 101.
Hi everyone. Welcome to RDLA's July legislative webinar and in-person meeting. We have a great lineup of speakers today, so I'm really excited for everyone to join. We have a lot of people online already, and we have a few people in the room as well. So we will be starting off with Joel White. He's the founder and president of Horizon Government Affairs, and he'll be giving us a background on ACA replacement and healthcare reform, and he'll be talking on behalf of the Council for Affordable Health Coverage. Next up, we'll have June Wasser from the Reagan-Udall Foundation, and she'll be talking a little bit about the Reagan-Udall Foundation's Expanded Access Navigator, and expanded access programs are extremely important for rare disease patients. So we'll be happy to have her talk about that. After that, Ryan Holman, the Vice President of Public Affairs at the Friends of Cancer Research, will be talking about the Food and Drug Administration Reauthorization Act, FDARA. Sometimes it's referred to as PDUFA. It's the whole package, PDUFA, GDUFA, MDUFA, PAZUFA. I know a lot of people don't like to hear that. There's the Prescription Drug User Fee Act. Then after that, we'll be hearing from Sarah Chang, who's the Director of Policy and Advocacy at Research America, about appropriations for FDA and NIH and the FY18 budget. And then our very own Stephanie Fisher will be talking about the OPEN Act, the Orphan Product Extensions Now Accelerating Cures and Treatments Act, as well as upcoming events like in-district lobby days and Rare Voice Awards. So I'm really happy to hear from everyone, and as soon as Joel comes back into the room, we'll start with Joel.
Sorry guys, too much stuff going on. So can everyone hear me okay on the phone? Everyone say yes.
Yep, I can hear you.
Okay. We're experimenting with some new microphones, so thank you for letting me provide an update on a simple, non-emotional, uncomplicated, perfectly sane process and bill. No, what's happening with health insurance markets, what's happening with healthcare reform is probably more appropriate, and what is Congress going to do or not do about it, and how can they fix what's happening. So just real quickly, we run a coalition called the Council for Affordable Health Coverage. It's been around since 2001. We're concerned that health costs are too high and they're rising too fast, and that's creating problems for patients in terms of accessing care and other issues. We're really diverse. We are, I don't know if I did that or if that's, anyway, we're a really diverse coalition. We're about 40% of the our members are large employers, but we have provider groups, insurers, we have PBMs, we have drug manufacturers, we have patient groups too. So we have a really broad perspective, but we're all focused on one core issue, and that's how do we make health coverage more affordable for people. So just by way of background, So by way of background, I think it's probably not an understatement to say that we've got some challenges in health insurance right now, and you know, the ACA did make massive changes to health insurance markets, and you know, it obviously created new consumer protections like lifetime and annual limits. It corrected a lot of the market imbalances that we saw, some of the abuses in the individual market with denials and pre-existing condition coverage exclusions and things like that. But it also, I think, overreached a little bit, and what we've seen since enactment and implementation is very large premiums, very large premium increases, very high deductibles, and very, growing deductibles. And, we'll get into some of the numbers on this, but that's creating some issues, right, and some problems. The other thing that we're seeing is, the risk pool is very unbalanced. There's a lot of high-risk people in the pool, and a lot of the younger, healthier people are not signing up. And that's also resulting in some markets having limited options in terms of plans and plan choices. So there's also, I think, right now, a lot of uncertainty created by the political environment. And that's causing uncertainty in the markets, and that's creating some problems in terms of access. So go to the next slide. The big thing that we're seeing in terms of, I'm just going to do kind of like where we're at in terms of today and what we're seeing coming up, and then we can talk about the bills and stuff like that. I'll give you my prognosis, but it gets, we can kind of talk offline too. But right now we're at the end of open enrollment, we had 10.3 effectuated enrollments. That was down for the first time from the February, you see the February 16th and the March 16th numbers, slightly down from the midpoint of last year. So fewer people are enrolling. Also, this enrollment represents about 45% of the eligible market. So fewer than half of people who are eligible to enroll in exchanges are actually enrolling. And what we know about these people is that they're older. They tend to have more diseases, more conditions. Age is a proxy for health, and they're also sicker. And they're demographically less diverse. We had expected more Hispanics to show up, and it's actually more white people who showed up. But the people that we need to make the risk pool healthier and more balanced are not showing up. And that's really leading to an unbalanced risk pool. And like I said, we've only got half the market participating. So we can kind of go to the next. And that's just some of the demographics. We did a report last year. We're updating the numbers for this year, but 2017, you can see we thought about half the market would be the under 35s. And it's turning out to about 37% of the market. And that big block in the 35 to 54 and 55 and older are really driving a lot of the cost. These are people who have rare and other conditions, chronic conditions. They have, definitely health challenges. And that's driving, and we know that from the claims experience that we see through some of the MLR data. So the risk pools are unbalanced. So right now, in terms of 2017, partly because of that unbalanced risk pool, we're seeing premiums, you can go 2 slides ahead. So we saw a 2% increase in premiums between 14 and 15, 7% between 15 and 16, 25% heading into 2017. That's an average. Some states are a lot more. A few states are less. There were some states and some counties with triple-digit premium increases, and we think that that reflects pricing up of the relative risk in the markets. And if you go to the next slide, underappreciated and underreported, I think, is this trend, and that's on the cost-sharing side. We're seeing very large deductibles, and in 2017, the deductible increased by double-digit rates. Currently, the average is about $3,500. The typical American has about $1,000 in their bank account. So this is a challenge. It's a challenge. It's getting pixelated and stuff, so it's maybe hippie-trippy too. So that 3572 is a real challenge for a lot of families, and you can see it's kind of increasing. And absent cost-sharing subsidy reduction funding, where lower-income people get help on the cost-sharing side, this is a burden, right? And there's a couple of reasons for it. First is for the premiums and the cost-sharing, health spending is increasing at about 7.5%. That's driving up premiums. Remember, medical loss ratios, insurers now pay at least 85 cents of every dollar on medical benefits. If medical costs go up, premium costs go up, out-of-pocket costs go up, right? So medical cost trends up, premiums are up, out-of-pocket costs are going up. The Obamacare reinsurance programs and some of the risk stabilization programs expired at the end of 2016. What Republicans have been talking about in the repeal replace bills, anywhere between $115 to $170 billion of new risk pool money on the table to help replace some of the expired programs. There's lower enrollment, which we already talked about, and there's fewer competition. We'll get to that in a second, but there's just fewer insurers showing up in the marketplace. So what do we expect for 2018, if you want to go forward? So the federal filing deadline was June 21st. We know from some initial CMS data that there's going to be fewer insurers in the market. We expect about 2.4 million people to have a choice of one or no health plans. The no health plans is concerning because there's an individual mandate that says if you don't buy coverage, pay a tax penalty. If there's nothing available on the exchange, you can't use your premium subsidy credit, right? You can't use your premium subsidy off exchange. There may be a plan there, but you can't use it for that. So what we expect to see is maybe Senator Alexander's bill on allowing premium subsidies off exchange to move forward in the Senate, depending on how health reform all kind of plays out. We also are thinking that premiums, we know premiums are going to be at least double digits, probably in some counties will be triple digit increases again, and we're going to see some additional cost sharing increases. The interesting thing, there was a Kaiser report that came out recently. It showed that the MLR, the loss ratios are stabilizing and are lower, which means that that's an indication of plan profitability. So some people are starting to speculate that the market may be settling down and becoming a little more stable, but stable for a high-risk population. So basically what some people are saying is that the Obamacare markets are maybe turning into heavily subsidized high-risk pool. Hi, Alan. I didn't even see you there. All right, so if you go to the map, I love maps. This is kind of what things look like. If you got folks in Ohio, Missouri, Washington State, you've got red areas. Those are areas with 0 carriers. The yellow or tannish are the 1 carrier counties. And this could all change, right? Some insurers could continue to jump out of the market. They might jump in. But again, it really depends on does the Trump administration cut off cost-sharing funding? Does Congress actually pass a bill? Does it not pass a bill, right? That will impact the plan decision to finalize the contract, which is going to happen in September. So let's talk a little bit real quick about Obamacare to Trump care. So I know from the community, I get a lot of questions about what's in the bill, what's not in the bill. I saw this blog post. Is this accurate? What's true? What's not true? I mean, I think we can answer specific questions. I think all of this may not matter because it doesn't appear that anything is going to pass the Senate or anything can pass the Senate. So, and I mean not just repeal, replace, I mean repeal on its own, and I mean a stabilization bill. And so if you're looking at a 2018 market that's, in my opinion, not very stable, it's high risk, premiums are increasing, cost sharing is increasing, choices are going down, people have 0 options, what do we as a community, what's our response, right? Because real people are going to actually have to deal with this. And if Congress can't do anything through the Senate, and if interest groups can't get together and say, like, at least do this, then we're going to have probably some pretty significant challenges next year. But,
Hey, Joel.
Well, yeah.
How you doing?
Good, good.
So I guess obviously the replace and repeal, I understand that that's gone. The stabilization, I guess I was surprised, and I know that it's going to be difficult too, but you seem to feel that that has almost no chance, because I know leadership is a little down on it, I get that, but then on the other hand, Alexander seems to want to go full force and willing to work across the aisle. But your assessment is that even stabilization is
I don't see how that gets through the House.
Okay.
I think that's less of a Senate challenge. I know Alexander's going to step in the breach here. He's going to try and get as much done as he can, and he's a good soldier for McConnell and has the trust of the leadership. But even if they cut a deal with Schumer, I don't know if Ryan and the House guys can get behind it.
Politically, you think that a good move on the House's part or a bad move?
I think it's a horrible move, right? So if you're working for a member, let's just say you're working for a member from Pennsylvania, right, and you're a moderate Republican and you've got 10,000 people whose premiums are going to go up by a couple $100 a month, right? Not a year, a month. And your answer is, well, the Democrats enacted it. It's Obamacare. The president said let it fail. That's not a good, right?
Yeah.
Or if you're in Ohio and you say, hey, I've got this premium subsidy, I can't use it, tough luck.
I guess that's why I feel there's still, and I agree with you that prospects are dead, but there's still some hope for the stabilization.
I just think the conservatives are going to say, screw you, if I can't get repeal, you're not getting money. Yeah. And it's corporate welfare anyway. Why am I giving money to a big insurance company?
Yeah.
And if the Senate can pass something, the House members will get hit twice. Once for voting for repeal, and then not voting for something that would stabilize the market. So, you have reason to hope there's going to be a lot of pressure on them, but my gut is the same.
No, I think so too. I guess
Ryan will bottle it up.
Yeah.
So you can go to almost the last slide here. We've got, like, and we'll make the slides available, and there's like summaries of the bill and stuff like that. But this is what CHC is working on. Like, when we started out in January arguing stabilizing the markets ought to be the top priority because you can't reform a market that doesn't exist anymore, I can tell you the response we got. In January it was, the only thing we're interested in doing is the cost-sharing reductions because that's a mandate on the plans already. And so maybe $6 billion, $7 billion. And fast forward 6 months later, and we're in this bizarre world where the conservatives are making health coverage more expensive and then throwing $70 billion to make it less expensive. So, like, people are willing to put money on the table to achieve a goal, and we've got an economist here who estimates that it's about a 60% discount. So every dollar I put into premium stabilization will lower the cost of the premiums by 60%. So if I put $10 billion into a premium stabilization program, it's only going to cost fiscally $4 billion. So it's a good investment of upfront resources to stabilize the market, and that's what we're going to push heading into September. Because I think there's a political price to pay, and I think there's a practical price to pay because people end up completely hosed, with no coverage, high cost coverage if they can get it, and coverage that they may not be able to use because
given economy that's part of CHC?
Yeah, we've got an ACA model that we've developed. He worked for CBO for 10 years, and we've got this ACA model that we've used in trying to help the Senate work through some options, and they didn't really listen to a lot of what we were saying at the end of the day. It got very political.
Joel, the pool of money that you referred to a couple of times, which I think is now up to, what, 180 billion but it's over 10 years divided by 51 entities, right. And it can be used for a lot of different purposes, not just. So I guess my question would be, granted that the total money is not as much as it seems to be, how much of it do you actually think would be directed for the purpose you're interested in and not for 16 other purposes that are allowed?
Yeah, there's two basic pots of money. One is premium stabilization, one is state innovation. Mm-hmm. So the premium stabilization is where we've focused a lot of our argument, but the innovation stuff is where a lot of Republicans want to give maximum flexibility to states to design programs, right? So we respect that. We think a lot of it would probably get built back into stabilization programs anyway. But what we suggested is the House did kind of like a straight run out. It was like $10 billion a year for 10 years. You talk to any insurer in the marketplace today, they care about 2018. They don't care about 2026, right? And so we said, take the money from 2025, 2026, put it into 2018, 2019. So what we were suggesting is front load the money, that'll have a bigger impact, right? So it was, what we're saying is more, $170, $180 billion, more in premium stabilization, and do it in a shorter time frame, 6-year period, say.
Okay.
So So it has a bigger boom, but like it's still, you get dinged on a 10-year basis. Doesn't matter how much it runs out. The other thing that CBO told, we met with CBO a couple times too, the other thing they told us was that absent some kind of a signal from HHS that they would change some of the rules around insurers accessing this money in 2018, they assumed zero impact in 2018. So you could spend $100 billion in 2018, and CBO would tell you it doesn't change the market. Another wonderful CBO invention. So we're also working with HHS to say, like, can you actually if they did a stabilization package, and we're arguing they should, can you work with the insurers to let them access this money in 2018 to change their premiums, change their cost sharing, so that people on the ground can actually benefit from a revised benefit structure and lower premiums. And they've been willing to do that, but again, it's going to be real hard to do this. I don't see how the Senate and the House go forward.
I also just want to say really quickly for people that are just listening in that you can send questions via the chat function in WebEx, and I can ask those for you to our presenters.
And at the end of the day, I think our big message is you can stabilize the market, but you do all this moving around in the insurance chairs. At the end of the day, what's driving the premiums are the health costs. And until you get your arms around the health costs, you're going to have those questions from constituents. Why did my premiums double? Well, because we never addressed healthcare costs. So we're working on a couple of campaigns, transparency, hospital costs, value-based purchasing in drug world, et cetera. So if you guys want to know anything about those things, we're here as a resource. And I can answer any of those questions, but I know you've got a packed agenda.
Yeah. So if anyone has any more questions, just send them via chat, or, we can get you Bill's email address. He has it right here on the slide, so if you want to reach out to him with any questions as well. So next we'll be moving on to Ryan, or to June, actually. Is June on the line?
Yes, I'm here. Can you hear me?
Yes, we can all hear you.
Great, thank you. Thanks so much for the invitation today. I'm pleased to speak with you about the Reagan-Udall Foundation and our new Expanded Access Navigator program. You can move to the first slide, please. For those of you who aren't familiar with our foundation, we were created by Congress in 2007 as an independent 501c3 to help support FDA and its mission, including promoting regulatory science and better public health. In all of our programs, we serve as a neutral party and bring together public-private partnerships to further some program in support of FDA's mission, and the Expanded Access Navigator program is an example of that, where we brought FDA, industry, trade groups, and patient groups together to look at this very important topic and decide what sort of program offering we could provide to the community to help. Next slide, please. The reason the FDA came to us is there is some confusion, particularly on the topic of single patient access, and that's where they asked us to focus the most. Our resource does cover the different ways you can get to an investigational drug, but delves deeper into the process for single patient access because it's less well known among the physician and patient communities. It even goes by many names, which is confusing to a lot of people. I want to mention that while the information on our website, which is the basis of the program, focuses on the process and how to get through it from a patient perspective and from a physician perspective, we have focused more on oncology just for the pilot of this program, and by that, it's not that the process is necessarily going to change greatly, but we have additional resources for physicians and patients to find additional information, and right now those are oncology, and we're certainly looking to expand those resources in the coming future. Next slide, please. So the expanded access landscape is very complex and evolving, as I'm sure all of you know. There's great increased visibility in the news via social media, lots of press. FDA has recently changed their activities to make it an easier process for physicians to get through. Legislative activities such as the 21st Century Cures Act there's a great desire by patients and families and their physicians to be more knowledgeable and have access to these drugs even when the safety or effectiveness is still yet unknown. And drug sponsors have to balance the need to provide the drug to the greater patient community and sometimes don't have an ability to provide a drug, but still need to be very responsive to patients and physicians. When we started to undertake this program, we did a scoping process for FDA last year, including a public meeting, which many of you may have attended. And in the investigation, you know, everyone realized there was very little data available on the administration and utilization of EA access overall. So that was part of what prompted this program. Next slide, please. So I don't want to get into the details of cures for this call, but only to point out that Avalier Health did a little interesting study back in September prior to the Cures Act going into effect, and then after did the same study again when Cures was enacted this year in 2017. They did the study in March comparing the transparency of policies on behalf of companies in terms of the requirement now to have public policies available regarding how to access, if they do offer expanded access, what the process is, who to contact, that sort of information. And to make it public, most companies do put it on their websites. So it was very interesting. Once Cures went into effect, the uptake more than doubled, and I'm sure it's increased since then, since March as well, given all of the public activity around the topic. Next slide, please. One of the features of our program, and it is a website with educational information and tools for both patients and physicians on explaining the process and how to get help and understand the roles in the process, is a corporate directory. And the idea was to make this a place where physicians and patients can go and all information would be in one spot and not have to chase down dozens of links to get to different pieces of information. So it makes our site a little bit different than some other sites that just have explanatory information and tools up. It's more centralized. We also did some preliminary work with Clinicaltrials.gov. They launched their site the same time we did a soft launch in June. We worked with them and created a user guide to help patients and physicians navigate Clinicaltrials.gov. They actually just redid their site, so it's a whole new site. And we're in touch with them about fields as they update their fields. They're honing in much more on the expanded access criteria so that they can link physicians to the drug under study and the company and so on. So there's a good synergy there, I think. Our directory also could be considered a resource for companies who are looking to develop policies, as it does include information from most of the larger companies around. To be useful, the directory has to be robust, and we're still in a process of getting word out and encouraging industry to participate in the directory. They can go online and complete a web form to input their information. It won't be published until we review it internally. As well, we're happy to just go ahead and input the information at this point for anyone who would like to be included. And the fields of information are on the form on our website. Next slide, please. So we did a soft launch of the Navigator in June. We're getting ready for a hard launch. We're just working with FDA on some announcements, and then our partners will follow up with communications. It's very important to get the word out for a couple of reasons. One, it will encourage companies to participate, and also this is an ongoing process for us, and we want to get user feedback from physicians and patients and others. Does the information make sense? Is there anything missing? Are there gaps that we can fill? Because we're still it's a work in progress, and we want to expand it, including beyond oncology. We'll continue to monitor legislative efforts and continue some fundraising to expand the program. But again, to encourage companies and get feedback from users is where we are right now, is in our efforts. Next slide, please. If you go to the website, I do want to point out there are several places, including the About page, where if you scroll to the bottom, there's a place to give feedback, and we encourage that. You can we will review it directly. It's not public information, just so you know, but any criticisms, helpful advice, even if you like it, what you like about it would be really great to know. Next slide. We thank our partners. We had a diverse group who had input into helping craft the content and share their own experiences and how they help and contribute to this space. Next slide, please. This is the website address, www.navigator.reaganudall.org, and we also have a special email address set up. Should you have any questions or want to provide feedback through that mechanism, you're welcome to do so. Anyone can use it, companies, patients, physicians, navigator@reaganudall.org. And I thank you very much.
All right, thank you so much, June. We haven't received any questions in the chat box, so if anyone in the room has any questions, you can feel free to ask June. If not, we can move on to Ryan. Oh, someone does have a question, actually.
So correct me if I'm wrong, you said market cap size and compared public postings doubled since the 21st Century Cures Act?
Yes, that was
Okay,
back in March. Yeah, more than doubled, yep.
All right, thank you so much, June. Ryan, are you on the line?
I am. Can you hear me?
Yes, we can all hear you.
Great. Thanks so much. And you can go ahead and go to the first slide. Thank you. Thanks, everyone. I'm here, and as Saba said, you'll hear this piece of legislation each time referred to as a bunch of different things. The last one to pass was PDAGA, so for the sake of this call, I'll just refer to this as PDUFA, the Prescription Drug and User Fee Act. I'm just going to go through a little bit of the history for some of you that might not know why this piece of legislation is so important. It's actually something that can and hopefully will move forward with bipartisan support and will be a positive act of this Congress in this uncertain time right now. So PDUFA was first signed into law in 1992. Back then, the FDA was much less the gold standard of global regulatory systems as it is today. And they began to look at how we can supplement FDA funding by requiring drug developers, pharmaceutical companies, to pay user fees when they submit their drugs for FDA review. In return for that, the FDA has agreed to set targets for completion times for their drug reviews and different points throughout the process, ensuring that a new drug application are observed in a timely manner. The bill, since its original passage, now there, as Saba mentioned, now includes generics, biosimilars, and medical devices and different user fee acts that those industries pay into. I'm going to focus on just the Prescription Drug and User Fee Act, which is the largest of them. To just give you a little snapshot of the incredible progress that PDUFA has actually made over the past 5 reauthorizations of this, is that the bill back in '92, it took around 27 months on average to review a new drug. And jumping forward to 2012, that is now down to half. And this has really allowed the FDA, the funding has allowed FDA to attract really top scientists and programs within the agency that are able to adapt to the science that is advancing at a rapid pace. And prior to that, it was very difficult from a budgetary standpoint to even kind of cobble together enough of the scientific programs that were able to keep pace with what industry and NIH and academic research centers across the country was producing. Next slide, please. So PDUFA 6, this has been underway for quite some time. The whole process starts between FDA and industry negotiating. This is prior to any congressional involvement. They seek stakeholder input from across the board and put out in 2016 an agreement letter between the agency and the industry. I've highlighted here just a few of the top-line issues. What we've seen over the years, PDUFA initially was just that, user fees to enhance the review of drug programs. What has happened over the past 5 reauthorizations is opportunities have arisen, and industry and FDA have agreed that user fees would be appropriate to enhance some of the scientific capacity and review capacity in other ways at the agency. For example, in the PDUFA 5 reauthorization, the breakthrough therapy designation was created as part of that designation to expedite therapies when exceptional use is seen early on in development. The PDUFA 6 reauthorization has a lot of benefits in there for patients. So directly strengthening efforts to incorporate patient perspective, look at having the agency look at PROs, and foster development of new medicines. And for sake of time, I won't go through each of these, but obviously there are substantial programs that are being expanded and funded through this. And I mentioned the breakthrough therapy designation before. That was created in PDUFA 5. However, there was no funding added to that, so the agency has seen the uptick in that designation be truly exceptional, but the funding is not there. So part of what PDUFA 6 is doing is funding some of the programs at the agency that were initiated in PDUFA 5, including the breakthrough therapy designation. The last bullet here is one of the most important in that it promotes the long-term stability and sustainability of FDA's drug review programs. And the under bullet here is there should be an asterisk to help ensure FDA can hire and retain strong scientific medical workforce. There's a caveat right now is we're approaching a quick deadline, and if you can go to the next slide. The deadline is quickly approaching at the end of September of when the reauthorization, the last PDUFA, will lapse. And there would be a layoff of almost 6,000 full-time employees if this were to occur. The reason there's an even more sense of urgency right now, and this is where multiple things within the U.S. Congress have become a victim of a lot of the political polarization that the Affordable Care Act's repeal and replace efforts has hampered. Normally, the PDUFA reauthorization in the past few iterations has been seen strong bipartisan support. The committees of jurisdiction in the House and the Senate this time around have been excellent and have strongly supported the PDUFA agreements and gotten them through committee. However, PDUFA has not yet seen the floor time scheduled for a vote because they have delayed it until the ACA repeal has been worked out. So these are the consequences. The unfortunate thing is, as we all know, with individuals that work at the NIH and the FDA, these are public servants that could be making more money in other places, and what they're seeing is their jobs and their livelihood being kind of toyed with a little bit, and what they'll begin to receive if Congress doesn't act by the end of July is notice of their termination in 60 days. So FDA is required to give 60-day notice. And Dr. Janet Woodcock, who's the head of the drug division, said that the last time they got close to this and had to begin to start to give notice, so they didn't have to lay anyone off, they lost over 500 of their key employees, and 800 to 1,000 total employees sought other employment because they, of course, needed job security, and they were getting notice that in 60 days they might lose their job. And it took the FDA years to recoup those scientists and those reviewers that are able to be there. So while the actual reauthorization expires September 30th, if Congress doesn't act before they leave for the August recess, those notice of pink slip will begin to go out. And because user fees account for 43% of the total programs, this is crucial for the agency. You can go to the next slide. So where we're at here, and when I I caveated my fellow panelists that I'd submit a slide and it would probably change. So here's where we were at. So the good news is that all of the committees of jurisdiction have passed this and are fully supportive of the agreement, strong bipartisan support. Now it just needs floor time. So what happened recently was the House, by voice vote, passed the PDUFA reauthorization bill and passed it on to the Senate. What we are waiting for and what happened just yesterday was Senate Majority Leader McConnell, who thanks to a lot of advocacy from probably a lot of groups on the phone, pushing and re-emphasizing the importance of getting this passed, used what's called Rule 14, which was that it moves the FDA reauthorization one step closer to being put on the floor, and it allows the legislation to bypass the committee and go straight to the Senate floor. He did this in the recognition with Senator Schumer that there is not time to go to the committees, and that since the committees have been through many hearings on this, unlike many of the other health bills we've talked about today, there's been very ample public hearings and public input from the FDA, from the committees in the Senate and the House, so they've really done an excellent job at this. So that's where the bill is at right now. So the mechanism is there for it to go straight to the floor. Senator McConnell has not indicated when the bill is expected. We continue to all push and implore Congress to do this as quickly as possible. We are hopeful that this will get done before the recess, and the previous slide with all those consequences of it not going through will not be necessary. So that's the quick overview of where it is now. This could change in hours, and the good news is that this is a bipartisan supported bill, and hopefully this can be, you know, even for a president that's looking for a win, hopefully he even sees that this could be a great win for that for the whole country. The other wrench in this that is from the administration standpoint, they've continually called for the FDA budget to be cut, and for that budget cut to be made up for by increasing user fees. That has been pretty flat out ignored by the Senate and the House, thankfully, because that's not how this functions, and it showed the administration's basic misunderstanding about how this process has worked over the past 5 reauthorizations. So you may hear a few things out of the White House about that, but know that the congressional champions, both Republicans and Democrats, have held strong and ignored those requests, and what is proceeding is what was agreed upon by FDA and industry back in 2016. So I will leave it at that. Thank you very much.
So much for that, Ryan, and I don't think any questions have come through. Oh, there's one question that actually came through for you. Has the Trump administration indicated support or concern about the PDUFA reauthorization?
I think just what I just mentioned a little bit, they have they don't quite understand it, is the bottom line, but they have indicated that they want the industry to pay more than was agreed upon. However, that's not going to be the case because this was the agreement that was reached. So I think they're getting close to realizing this can be, you know, this could be that first big bill that he signs, and he can take credit for it if he wants, just as long as it gets through.
Yeah. All right, well, next we'll have Sarah talk about appropriations for, oh, actually there's another question before we move on.
Just a quick question, and it's a long shot, but obviously since the administration has called for this at least twice, of doubling the user fees, what is the likelihood, or what would happen if the bill reaches the president's desk and he has to sign it into law? Is there a possibility that there'll be wrangling at the last minute? Have you perhaps heard anything about that, or?
Yeah, the indications, and I shudder to say this out loud, is that that it's a lot of posturing, and that he will and has spoken to leadership that he intends to sign the agreed upon bill. That being said, I think we all know that we can't rely on consistency out of the White House right now. But I don't think there would be, there is such strong support for what currently exists, especially from Leader McConnell and Chairman Alexander, that we don't foresee that being an issue once it gets through.
Actually, Ryan, I was just going to add that I think what surprised and pleased us was that we were pretty sure the authorizers weren't going to be very interested. And in theory, that really doesn't leave the appropriators with any options.
Yeah.
They could have complained. They could have said, gee, we wish. They could have cut FDA, and they haven't. So this really is not just a core of support in the authorizers. This has been replicated among the appropriators.
Yeah, that's a good point.
All right, thank you so much, Ryan, and thank you everyone for asking your questions. So now we're going to move on to Sarah.
Great, thanks, Fda. I'm happy to be here today. I'm with Research America, and we can go to the next slide. We are the nation's largest nonprofit education and advocacy alliance, working to accelerate medical progress and strengthen our nation's public health system. We have nearly 400 alliance members, crossing the full broad spectrum of the medical and health advocacy spectrum. So to take a dive today, similar to the previous presenters, it's been a lot of fast movement that has felt like it may be not going anywhere. So it seems like in the media everything is moving quickly, and perhaps things are actually not going as fast as it seems. But as far as FY18, the community has come together, and for FY18 we asked for a $2 billion increase to NIH and a $2.8 billion increase for FDA, and encouraged appropriators to release the targeted funds for both the NIH Innovation Account and the FDA Innovation Account. So the NIH Innovation Account for FY18 is $496 million, and FDA $60 million. But the challenge with our ask for this year is that sequestration is coming for FY18. So there was a reprieve for FY16 and FY17, and that will come into full force for FY18, which is $5 billion less than FY17. So that presents a real challenge to appropriators with what they have to work with. And a large portion of this cut comes from the labor age bill, which is where the NIH funding comes from. So recently, Research America put together a Raise the Caps letter, and we are encouraged, and I know they've seen others in the community encouraging leadership, House and Senate leadership, to discuss a budget deal. There were 210 organizations on the current letter that we sent out. So there's a lot of support, and we've heard a lot of support in the House and Senate, and I think Senate Democrats also put together a letter encouraging leadership to consider this, but whether something happens sooner rather than later remains to be seen. Just a quick note on why the NIH and FDA, why do we advocate for those areas? The NIH, as you know, is the world's largest public funder of biomedical research, and the FDA is responsible for protecting and promoting public health through the control and supervision of food and drug products. So both of these are vital programs to almost all of our core missions around the table. Next slide. So the FY18 labor HHS appropriation status. So it has moved recently. So there are 12 appropriations bills. The House subcommittees have passed all 12 bills, and the committee has passed 10 of the 12 bills. Labor HHS is being considered today in the full committee. or it might have already been. I know it started at 9:30 this morning, so it's hard to keep up. And the Senate has only, subcommittees have only considered 3 bills, with the full committee only considering MilCon VA so far. So there's a little bit of movement, as everyone has noted. The Senate is a bit congested recently. So July 12th, the House Appropriations Committee had their markup, or the 13th they had their markup, and it was passed along party lines. And then today is the full markup. The Senate has not said when they are considering putting it on the calendar yet. Let's see. We can go to the next slide. So from the House side, the bill provides $35.2 billion for NIH. That is an increase of $1.1 billion over FY17. So as I said earlier, we were asking as a community for $2 billion plus CARES funding, but our House champions, Congressman Tom Cole, has worked really hard to get the $1.1 billion that we have. That is inclusive of the $496 million in 21st Century Cures funding. So we are very thankful to Chairman Cole for being a champion for NIH. I know that he had some really tough choices that he had to consider in order to make that increase. However, just as a note, their effective of inflation, this is comparable, the 35.2 is comparable to FY 2010 levels, just to kind of give everyone a little bit of a perspective. And the next one are just 2 quick. So this one shows where NIH funding is after FY 2017, and then the next one shows kind of where we were hoping it would be, but we're at least still in that upward trajectory, hopefully, if all goes to plan. We do know that while the Senate has not released any draft bill, that Chairman Blunt is also very supportive of an increase to NIH. So we are hopeful that there will be something there for NIH as well. The next slide, just to talk a little bit about FDA appropriations. So the FDA, the House Appropriations Committee already passed the Ag bill, and included in it was $2.8 billion for the baseline for FDA funding, and also the $2.4 billion that's being discussed in the PDUFA, the user fee reauthorization. And then also included is $60 million from new funding being released from 21st Century Cures. And it looks like my FY18 is a little bit different from Ryan's, saying 46% coming from user fees, and I think his was 43. But I'll leave that to his expertise. As far as movement for this, so the House Appropriations Committee has passed the Ag bill. The Senate is still to be determined, and so I think that's kind of where we're at. So the next one, again, so this shows you that 2017, 2.7, so I think most of the community is technically saying that the FY18 appropriation discussion is technically flat funded, but it's not a cut. So anything, we're counting anything as a win right now. You can see the next slide is what our FY18 ask. And I think that's the end of my update for now. And I'm happy to take any questions.
All right, thank you so much, Sarah. If anyone has any questions, you can reach out via email. She has her email right here. And so I guess we can move on to Stephanie. Stephanie, are you on the line? On here. Let's see if I can. says she's here, but I don't hear her, so let's try.
Saba?
Yes, Stephanie, we can hear you.
Okay, excellent. Thank you. I will go over this fairly quickly. We have talked about OPEN several times this year. For those of you who may not know what it is, it's the Orphan Products Now Accelerating Cures and Treatments Act, called OPEN Act. It has the potential to double the number of rare disease therapies approved by FDA to treat rare diseases. Given only 5% of the rare diseases have an FDA-approved treatment, many of us, many patients currently use therapies off-label, and there are certainly disadvantages to this. So this would help get some of the off-label indications ideally on the label, which would mean clinical data for patients and their doctors to look at, and it would also increase the likelihood of insurance companies covering the treatment. So certainly both of those are good for patients. The mechanism would be, these are already approved medicines, and the OPEN Act would provide 6 months of exclusivity for an approved medicine to have an indication for rare disease added to the label. So this is much more, this is a much faster process than traditional drug development when you start with a bench and go all the way through the phases of clinical development, the FDA review and approval, because these medicines are already approved, they've been found safe and effective, and the biopharmaceutical company would need to do much less research to get the new indication. But currently this isn't happening enough, so this is why we need the OPEN Act that provide that additional incentive to biopharmaceutical companies to do the research necessary to get a rare disease indication on the label. Another benefit to patients is because these medicines have been approved for a more common disease, they are priced for a larger market. So we also look at this as a way to bring down the average cost of medicines to treat rare disease. Next slide, please. So the OPEN Act was included in the 21st Century Cures Bill that passed the House in July of 2015, but it was not in the version that ended up being signed into law last December. It is bipartisan. It's supported by 225 patient organizations. It's been reintroduced in the House by Representatives Bilrakis, Butterfield, and McCall, and thanks to rare disease advocates who took part in Lobby Day during Rare Disease Week, and other advocates who called or took action through our website to send an email. We've added an additional 19 co-sponsors, and those are in both parties. And then we had the bill more recently introduced in the Senate at the very end of June by Orrin Hatch and Senator Menendez of New Jersey. Next slide, please. So how can we ensure that this bill is passed? Again, this is very good news for patients. It's going to mean more FDA-approved medicines much sooner. So if your organization is not already one of the 225, we would love to be able to add your name to show even broader community support. If you're not sure, please send an email to Saba or to me, and we'd be happy to check. The letter of support is on our website, which is included on this slide, so you can check, but I'm more than happy to answer if you're not sure. We have an action alert also on our website and on the RDLA website as well. It's very easy. It only takes a few minutes. You only put your address in once, and it will send a letter to your senators and representatives. If any of them are already a co-sponsor, they'll get a thank you instead of a request to join. And so if you can, anyone who hasn't yet taken action, we'd really appreciate it if you can. It will only be a few moments. And then please help us reach more people and share the action alert in your network, included in your emails. If your organization has a newsletter, post it on Facebook. I'm happy to share sample tweets with anyone who's interested to make it as easy as possible, because we really need the rare community to help us get this enacted into law. Next slide. Another way to help get OPEN Act in front of your senators and representatives is by joining us. And that date is not quite right. joining us by participating in in-district lobby days. Those are actually July 31st through September 1st. And we have more than 200 advocates from across the country signed up right now. Registration is open through tomorrow, actually, so if you can sign up by tomorrow, we will be able to, we'll work to schedule meetings for you with your senators and representatives in their local district. Next slide, please. And we will work around your availability. So you're able to say when you're on vacation, if you have doctor's appointments, you don't need to tell us what you're doing, but when you register, you're able to say not only how far you can travel, which will help us determine which of the local offices you can go to. For instance, if you live in Pittsburgh, we don't expect you to drive to Philadelphia to meet with, you know, Senator Casey and Toomey. So we do the meetings as close to you as we can. Part of that depends on how many other people in the state. It's a little tricky in Texas because there are a lot of advocates from across the state, but we do our best to make the meetings as convenient as possible to the most number of advocates who want to join us. And the goals of in-district lobby days are really to strengthen relationships. We had approximately 325 rare disease advocates join us for Lobby Day in DC during Rare Disease Week on Capitol Hill. So for those folks, this is a chance to build on the relationship and follow up. You know, if they ask their member to join the Rare Disease Caucus, if they ask them to support the Open Act, this is a chance to follow up, thank them for the action they've taken, or remind them of the outstanding items that they asked for that haven't been done yet. One of the things that I love about this program is there's no requirement to talk about a specific issue. Each advocate can set what are his or her priorities. Is it funding for NIH and FDA? Is it sharing your views on healthcare reform? What should or shouldn't be in healthcare reform bill? Is it the Open Act? It's up to each person to decide. There's no requirement to support any specific legislation. And again, we really want every member of Congress to hear from members of the rare community so that he or she has our perspectives in mind when they approach issues such as healthcare reform. It really helps to know that members of their local community who come in to meet with them in their local office, you know, have concerns about coverage or whatever concerns that his or her constituent shares with them. In order to help everyone prepare, we're hosting a webinar next Friday, July 28th. It will be available online for anyone who can't join us. We'll be going over key issues. We still need to find out what those are because, as you've heard, you know, PDUFA reauthorization's a moving target, healthcare reform's a moving target. We usually pick between 4 and 5 that we've heard from other community members are the key issues, and we'll go over those. Like I said, there's no requirements to talk about specific issues. You're welcome, and we'll have information on the webinar about creating your own one page if you want to bring background information on a different issue than what we address. We'll give you tips on an effective meeting. We certainly allow a lot of time for questions because folks, whether they're new or they've participated before, have questions, and we want to make sure that everyone who participates feels prepared and is ready to make the most of the time that they have with a member or their staff to really make an impact. And this is the website. We already have some resources up there, like legislative scorecards from the last Congress. So if you have a new member, this may or probably won't be helpful, but if you have a senator or representative who served in the last Congress and was either reelected or for the Senate is still serving that initial 6-year term, you can see how did they vote on key issues. Is he or she already a member of the Rare Disease Caucus? So again, we give you as much information as we can without being overwhelming to help you prepare for really effective meetings. And finally, then we will all release you. the Rare Voice Awards is an annual event hosted by rare disease legislative advocates, and it recognizes not only patient caregiver advocates, we also recognize congressional staff. We know that members are critical. They're the ones to actually sign on the bills, to sign onto bills and vote, but it's the staff who can really make a difference. They're the ones who bring issues to the members. They're the ones who bring handwritten notes. They do a lot of background work. They coordinate with other offices behind the scenes. What do we need to get your boss on this bill? and I happen to work with Joel White on the Hill. I can tell you he was a very effective staffer. So we want to recognize them for all of their hard work. So if you have, if you've been working closely on with congressional staff on a certain issue, again, it can be any federal legislative issue, this is a great way to acknowledge their hard work. They get to go back to the member and say, hey, guess what? I was nominated for my service to the rare disease community. The form should only take maybe 10 minutes to fill out. It's a great way to recognize advocates and staff. We also last year added a state legislator category in recognition of the great work that state legislators are doing, whether it's creating a rare disease advisory council at the state level, which happened within the last month in Pennsylvania, maybe leading the charge for newborn screening, which passed in Florida within the last few months. So this is a way to really recognize the great work being done for the rare disease community. Nominees are featured in a video that we show at the awards, and they're in the program book. So even if they don't win, it's great recognition, and it raises awareness of their office or their organization. So if you have someone who's really helping the community, we encourage you to nominate him or her by July 31st. Next slide, please. The awards themselves are open to the full rare disease community. They are free. It's great networking. We have a cocktail reception beforehand, the award ceremony, and then a celebration afterwards. So we get officials from FDA, NIH. We get a lot of congressional staff. We usually have several members of Congress join us. Senator Hatch was there last year. So it's really a wonderful event celebrating the community. And again, it's free. Next slide, please. And that is, and we will offer it for free thanks to the generosity of the sponsor. So please mark your calendar. It's November 15th in DC at Arena Stage. We don't have registration up yet, so look for that probably in late September, but we'll be talking about it in a future RDLA call, so we'll certainly make sure anyone registered for today's call gets an invitation. And I am happy to take questions on any of those three issues.
Thank you so much, Stephanie. It looks like we already ran a few minutes over our time, so I will be posting these slides later, and they have the email addresses for all of our speakers. And if you have trouble finding their email address, please feel free to email me, and I can ask them any questions that you have. And I'd just like to thank our presenters again. Thank you so much for joining, and thank you so much for sharing all your expertise. And thanks to all the attendees as well. So have a great day.
Thank you.
Thank you.